Hey, critical care champs! When a diabetic patient arrives confused, dehydrated, and in metabolic crisis, every second matters. Today, we're breaking down diabetic ketoacidosis and hyperosmolar hyperglycemic state, two life-threatening emergencies that demand fast thinking and even faster action. So let's talk about DKA, or diabetic ketoacidosis. This is seen primarily in type 1 diabetes. It's caused by absolute insulin deficiency, which means the cells are basically starving for glucose. As a result, the body starts breaking down fat for energy, leading to ketone production and, ultimately, metabolic acidosis. Now, HHS, or hyperosmolar hyperglycemic state, is more common in type 2 diabetes. It's caused by relative insulin deficiency, and extreme hyperglycemia leads to severe dehydration and increased serum osmolality, but without significant ketosis. Bottom line here, DKA means acidosis and ketones, while HHS means severe hyperglycemia and dehydration, with minimal or no ketones. Alright, let's look at the signs. For DKA, you'll often see Kussmaul respirations, that classic fruity breath from acetone, nausea, vomiting, abdominal pain, altered mental status, glucose greater than 250 milligrams per deciliter, a pH less than 7.3, bicarb less than 18, and positive serum or urine ketones. For HHS, look for profound dehydration, severe confusion or even coma, weakness, vision changes, glucose over 600 milligrams per deciliter, serum osmolality over 320, and typically normal pH with minimal ketones. And, just so you know, common triggers for both include infection, missed insulin doses, myocardial infarction or other acute illnesses, and certain medications like steroids. Alright, let's walk through the emergency nursing interventions step by step. First up, fluid resuscitation is the initial priority. That means giving a bolus of 0.9% normal saline. And remember, it's really important to monitor for fluid overload, especially in elderly patients or anyone with cardiac issues. Next, we move on to insulin administration. You'll want to start an IV insulin infusion, but only after confirming that the patient's potassium is at least 3.3. The goal here is to lower glucose gradually, by about 50 to 75 milligrams per deciliter per hour. Now, let's talk about electrolyte replacement. Potassium needs to be monitored and replaced closely since insulin will shift potassium into the cells, increasing the risk of hypokalemia. Also, don't forget to watch sodium, phosphate, and magnesium levels. Monitoring for complications is crucial. Keep an eye out for hypoglycemia, cerebral edema, especially in children, as well as ARDs, arrhythmias, and renal failure. And finally, frequent labs and vital signs monitoring are essential. Check glucose, ABGs, and electrolytes every 1 to 2 hours. Maintain strict intake and output records, and ensure continuous cardiac monitoring. Early recognition of those subtle symptoms can actually prevent a full-blown crisis. It's so important to educate patients on sick day rules and the importance of sticking to their insulin regimen. Be sure to collaborate with your interdisciplinary teams, like the emergency department, ICU, and endocrinology. Prompt intervention isn't just life-saving. It can shorten ICU stays, reduce complications, and really improve overall recovery. In the race against time, nurses are often the first to spot the signs and the ones who stabilize these patients first. So trust your gut, check those labs, and act fast. Hey, have you managed a critical case of DKA or HHS? Share your go-to interventions in the comments. And don't forget to like, subscribe, and follow for more endocrine emergency breakdowns. Because honestly, your skills are the difference. And remember, rehydrate, rebalance, rescue.